Hi guys, welcome back. This is Dr. Deepak Marwa and today we shall be talking regarding ABG aspects. We'll be talking about how to analyze the ABG reports. I'll be discussing some numerical values with you so that things become relatively simplified. As you can see in this particular image, a doctor taking a ABG, you need to keep the needle at 45 degrees so that you can puncture the radial artery. The arm should obviously be extended. So we'll talk about procedural aspects related to ABG. We'll talk about some of the contraindications when we should not be doing it, and most importantly, like for the AIIMS exam, they ask about numerical values and they ask you to calculate whether it's a compensation, whether it's a partial compensation, whether it's a full compensation. So I'll try to do justice and explain to you how to solve those particular questions related to the compensation part. First and foremost, you should be comfortable with the fact that in questions which are related to respiratory acidosis, whenever there is an increase of carbon dioxide in the body, it is going to be generating protons. If you look at this chemistry equation, as I have emphasized earlier, you would obviously be having generation of protons and you'll be having generation of bicarbonate. My point is, guys, that once the carbon dioxide values will spike, there would be a excess synthesis of hydrogen ions in the body of this patient, which will cause the pH to fall. Now, once you have a acidosis developing in the patient due to a respiratory problem, which is causing a carbon dioxide value to increase, you should be having a compensatory increase in the value of bicarbonate to neutralize the increase of hydrogens. This bicarbonate increase will be the courtesy the kidney. The proximal convoluted tubule of the kidney is capable of alkali reabsorption. So once there is a respiratory acidosis developing in a patient, the body sends a signal to the kidney that, sir, we need your help, and the kidney will oblige by upgrading the values of bicarbonate in the body of this patient. Once the bicarbonate values will increase, the pH will begin to stabilize and the patient will be said to be fully compensated. The mathematical rule which most guys are interested in, an examiner is interested in, is that if carbon dioxide increases by 10 millimeters of mercury, then bicarbonate should increase by approximately 1 milliequivalents. Let's take it mathematically. If carbon dioxide increases from, let me say, average of 40 to 50 millimeters of mercury, then bicarbonate should increase from a normal value of 26 upper limit to 27 milliequivalents. So the rule is 10:1 rule, which is valid for acute compensation in respiratory acidosis. In some MCQs, he might say the word chronic compensation. For chronic compensation, the rule is 10:4. That for 10-point increase in the value of carbon dioxide, the bicarbonate should increase by 4 points, and we'll be applying these mathematical values as we progress. The point is 10:1 rule, 10:4 rule. It is acute compensation versus a chronic compensation. The basic point is, in all questions of respiratory acidosis, carbon dioxide always has to be increased. That's the basic rule. Carbon dioxide has to increase, and to neutralize this carbon dioxide, bicarbonate values should also be increasing. So let's quickly evaluate what are the causes for development of respiratory acidosis. And one of the simplest ways to understand this is, if you just remember the word depressed, the things will fall into place. Let me say this is the brain of the patient. If a person is having a cerebrovascular accident like a stroke, and that is contributing to damage to the respiratory center, then the hypoventilation of the patient can contribute to development of carbon dioxide buildup. Drugs like morphine can cause respiratory depression. Opioid analgesics can cause respiratory depression. Sedatives which are given to the patient can cause respiratory depression. Anesthetic drugs can contribute to respiratory depression. The point of mine is that if the respiratory rate of the patient is reduced, the carbon dioxide values will begin to increase. Even CNS infections can contribute to damage to vital centers like the respiratory center, and therefore carbon dioxide values can increase. This would be called as central causes for respiratory acidosis. On the other hand, let us now pick up possibility of airway related causes for respiratory acidosis in a patient. This is a crude diagram which is representing the lungs of the patient and the airways. Obviously, you will be having this tracheal bifurcation followed by bronchi, bronchiolar divisions, subdivisions, multiple generations, and then you reach the smallest units, that is the alveoli. Now, one possibility can be that patient could be having an obstruction here, like I have shown a physical obstruction that could be a foreign body Usually the foreign body is unlikely to go into the subglottic area, especially in children. Like you usually find that subglottis is narrow, so you could be having a foreign body impacted at the level of the vocal cords or below it, and therefore the physical obstruction will cause a acute onset respiratory acidosis. Then I can slightly modify the diagram by saying that if a person is having a significant bronchospasm, very significant bronchospasm and airway obstruction can be encountered in patients of severe asthma exacerbation, or for that matter of fact with bronchitis. So asthma exacerbation, especially severe asthma, which was earlier called as status asthmaticus, can cause a buildup of carbon dioxide in the body. If I come to the smaller airways, that is bronchioles, it could be COPD exacerbation. As you are all aware, COPD is a disease of the smaller airways which involves mainly the respiratory bronchioles. So therefore, I have shown a COPD exacerbation as one of the causes. Then could be causes which could be related to the alveoli and beyond the alveoli. One of the causes related to the alveoli can be that if they rupture, there could be a pneumothorax in a patient that can contribute to hypoventilation, carbon dioxide buildup. So barotrauma can contribute to it. Another cause for this could be ARDS of the severe variety. You see, when ARDS will develop initially, patient will hyperventilate, but in the later part, when there's a ventilation perfusion mismatch developing in a patient of ARDS, you would have a buildup of carbon dioxide in the body of the patient. Then I can write a occupational lung disease which could be present in and around the, which will cause fibrosis in and around the alveoli, that is pneumoconiosis. So what I have done here is that I've shown big airways, then I've shown relatively smaller airways, the bronchioles, and then I've gone to the level of the alveoli and showed why could you be having a buildup of carbon dioxide in the body. Now let us take this to be the representation of the chest wall. So there could also be a possibility that in the patient, it is the chest wall that is involved in the patient in contrast to the airways. Now when I say the chest wall, I don't mean only the chest wall, I also mean the muscles related to respiration. So we could be having like poliomyelitis affecting the muscles of respiration, myasthenia gravis affecting the muscles of respiration, amyotrophic lateral sclerosis affecting the muscles of respiration, muscular dystrophy affecting the muscles of respiration. So my point is that if you are having any disease related to muscles of respiration like poliomyelitis, muscular dystrophy, that could contribute to development of respiratory acidosis developing in a patient. And obviously there would be then some miscellaneous causes like obstructive sleep apnea or development of loud snoring followed by apneic episodes in a patient. Obesity is again one of the important confounding risk factors, especially increased neck circumference. I mean, increased neck circumference increases incidence of not only snoring, but it increases the incidence of obstructive sleep apnea in a patient. So I am just gonna use a small mnemonic to highlight causes of respiratory acidosis in a patient, and you can just remember this word depress. What I mean by depress is drugs could be depressive. What I mean by D could be diseases of the chest wall, diseases of especially the neuromuscular junction, which could be affecting the performance of the muscles of the chest. By the E component, I mean the edema component. This edema could be cardiogenic or it could be non-cardiogenic edema, and a non-cardiogenic edema that I mentioned before you is ARDS. P would stand for pneumoconiosis, which is a occupational lung disease, and this would be associated with significant fibrosis in the lung and impaired exit of carbon dioxide because of the fibrosis component. R would stand for respiratory center depression. Conditions causing respiratory center depression could be stroke, it could be CNS infections, it could be drugs like morphine and sedatives. S would stand for spasm. Spasm would stand for, bronchospasm. That could be asthma exacerbation, it could be COPD exacerbation that could worsen the status of the patient. So whenever you think about respiratory acidosis, guys, you have to remember the word depress so that you can actually work out what actually is happening to the patient. Remember the fact that carbon dioxide is responsible for dilation of brain blood vessels. So whenever carbon dioxide increases in the body, the cerebral blood flow tends to increase. That can actually cause swelling in the brain of the patient. Your objective is, one, you need to kick out carbon dioxide for two reasons. One, carbon dioxide needs to be kicked out of the body primarily because it causes carbon dioxide narcosis. Second, it causes increased features of rise-icity. I'll say that again. carbon dioxide narcosis and features of raised ICT can be encountered in patients of carbon dioxide narcosis. Why I said that is because it will increase the cerebral blood flow, and therefore papilledema could be written in a MCQ of a person having respiratory acidosis. For treatment of this patient, elective intubation will be recommended, positive pressure ventilation will be recommended so that I can kick out the carbon dioxide and save the problems of the patient. Aggressive treatment should never be done, because if you do aggressive treatment, like I have taught in metabolic acidosis, don't aggressively treat the patient. Here I am saying aggressive treatment will cause a carbon dioxide washout. Carbon dioxide washout will cause loss of vasodilator property of brain blood vessels, due to which now the opposite will happen. This will contribute to decrease in cerebral perfusion. This explains the fact that why in a patient of respiratory acidosis, when you aggressively treat the patient, it might actually contribute to seizures in a patient due to sudden global hypoperfusion of the neurons. The underperfusion of neurons can trigger seizures in a patient. Looks very surprising when you read it the very first time, but remember the fact, the statement of mind, carbon dioxide has a vasodilatory effect on brain blood vessels. Too much of it is bad, too less of it is bad, and if you let it rise, obviously the patient's brain will be definitely depressed. The clinical features of the patient could range from something as simple as anxiety and hallucinations to asterixis that can be demonstrated. Similar asterixis that you demonstrate in metabolic encephalopathy like uremic and hepatic encephalopathy could be present. Patients of carbon dioxide narcosis could be having an increased daytime somnolence. Patient will sleep most part of the day. And then obviously question could mention regarding papilledema. The features will look like that of raised ICT. That's, as I said, due to primarily the vasodilatory effect. Now, please remember the fact that when it comes to respiratory alkalosis in a patient, I'll just show you the mnemonic again, depress, where the carbon dioxide is building up, and the rule to be remembered is 10:1 and 10:4 for acute and chronic compensation. We have to study regarding respiratory alkalosis. Now, when it comes to respiratory alkalosis in a patient, I'll just write the chemistry equation again so that you can just get used to the mathematical rule here. You all know from basic sciences that carbon dioxide will combine with water to cause production of H2CO3 that will break down to form hydrogen ions and bicarb. If you have carbon dioxide washout from the body, why? Because there's a carbon dioxide washout, the patient is exhibiting hyperventilation. This guy is like a mountaineer. He has gone to high altitude area, and in high altitude when you breathe faster, carbon dioxide is kicked out, so less H2CO3 will be formed, and therefore less protons will be formed. And if the protons are lesser, then chemistry wise I'm saying bicarb should become lesser. So in all questions of respiratory alkalosis, protons are becoming lesser, so bicarbonate should also be becoming lesser. And well, how is this gonna happen? The kidney in this particular case will basically help in causing a bicarbonate loss via the proximal tubule of the kidney. Look at the words that are saying. Earlier I was saying that in respiratory acidosis, the bicarb will increase to counteract the protons. Here the bicarb would be lost by the tubules because we don't need them because there is less hydrogen in the body. The rule to be remembered in this case is that if carbon dioxide decreases by 10 millimeter and you find the fact that the value of bicarbonate is reducing by 2 milliequivalents, instead of 2 milliequivalents 4, then it is chronic compensation. Remember my statements, 1 and 4 is for respiratory acidosis. I'll show you that slide again. 1 and 4 is for respiratory acidosis and 2 and 4 is for respiratory alkalosis. What are we talking about? Compensation. In respiratory acidosis, more carbon dioxide, you need more bicarb to stabilize the protons. The ratio is 10:1, 10:4. For every 10-point increment, 1 point increment of bicarbonate, 4-point increment of bicarbonate for acute versus chronic. Coming to respiratory alkalosis, the number is 24. So remember two numbers, 14 and 24. Now, when it comes to respiratory alkalosis in a patient, we can quickly evaluate the causes in a similar ground like we talked about for respiratory acidosis, and then we'll be on our way for the mathematical questions that you're waiting for. One of this could be CNS cause. What I mean by CNS cause could be patient could simply be having pain. It could be something as simple as anxiety of getting a surgery done. It could be hysteria. Hysterical behavior can also contribute to respiratory alkalosis. high grade fever in a patient can contribute to it. Cerebrovascular accident can contribute to it. So CVA can be causing both manifestations of alkalosis or acidosis dependent upon whether the respiratory center is destroyed or not. If respiratory center is destroyed, it is a hypoventilation in a patient. Now let's look at the airways. This is the segmental bronchus, the subsegmental bronchus, smaller airways then. And we reach up to the alveoli. So we're going to talk about possibility of disease that could be present in the lungs of the patient. One of them could be obviously pulmonary edema. This pulmonary edema that I'm talking about at the moment is cardiogenic pulmonary edema, congestive heart failure. In patients of congestive heart failure, patients usually tend to breathe very faster, and therefore in these patients, because the heart failure, the pulmonary edema contributes to activation of the J receptors, the patients will breathe very fast and will contribute to development of respiratory alkalosis in a patient. When I say that, a lot of guys, they send me a query saying, on one hand, in ARDS, you were saying there's a respiratory acidosis. Now you're teaching is respiratory alkalosis, is presentation of heart failure. I mean, both are having pulmonary edema. So, how is it? Is it cardiogenic or non-cardiogenic that is causing the difference? Let me explain. In patients who are having ARDS of the severe variety, there's a ventilation perfusion imbalance. Two things together. There's a ventilation problem, there's a perfusion problem. So because the blood vessels are constricted in ARDS, listen to the ARDS lecture for that. The blood vessels are constricted in ARDS, so gas exchange is totally compromised to the level that oxygen can't come in, carbon dioxide can't go out. So in the later part of ARDS, the severe variety where you have a presence of a ventilation perfusion imbalance, you are having a respiratory acidosis. In congestive heart failure, the problem is mainly fluid in the alveoli. The blood vessels around the alveoli are fine. There's no collapse of blood vessels around the alveoli. Rather, they're having more blood. In ARDS, those blood vessels around the alveoli are collapsed. They are constricted because of the severe hypoxia. Here, I am saying the blood vessels around the alveoli are dilated, carrying more blood, and there is only edema in the fluid in the alveoli of the patient that will activate the J receptors, and therefore the person will breathe faster and there would be a respiratory alkalosis in a patient. Then is obviously high altitude pulmonary edema. Same logic, that high altitude pulmonary edema will be causing fluid in the alveoli. So get the concept right. If you have only fluid in the alveoli, you will hyperventilate. If you have fluid in the alveoli and you have constricted blood vessels around the alveoli, then you don't have a alkalosis, then you have a acidosis present in a patient. Then he could obviously write conditions like pulmonary embolism, which could contribute to respiratory alkalosis in the initial phase, fast breathing in a patient. Then a flail chest is also included in causes of fast breathing and can contribute to respiratory alkalosis in a patient. Then miscellaneous causes could be like septicemia. Miscellaneous causes could be like heat exposure. He can talk about heat hyperpyrexia. So these are some of the clinical scenarios that might be given in the question, and by reading these clinical scenarios, you should be immediately able to understand the fact that in the patient there is a development of respiratory alkalosis. Now let us look at the symptoms of respiratory alkalosis, what respiratory alkalosis causes to patients. As I said, carbon dioxide has a vasodilator effect on the brain blood vessels. If carbon dioxide becomes lesser, the vasodilator effect of carbon dioxide will go away and the cerebral blood vessels will be now constricted, so cerebral perfusion will be reduced. Just for the sake of completion, I would like to write this, though I've said it 2-3 times. Carbon dioxide has a vasodilator effect on cerebral vessels. In the patient, because carbon dioxide is lesser, so the vasodilator effect is gone and there is a underperfusion. This explains the fact that why in respiratory alkalosis do you have dizziness, you are having presence of vertigo. Do not mistake it for excessive sleepiness of the patient. Excessive sleepiness is a buildup of carbon dioxide, that is respiratory acidosis. I'm not saying he's sleepy. There's a difference between being sleepy, right, and dizziness in a patient. Remember the fact that carbon dioxide, when it is less in the blood, there is a intracellular shift of sodium, potassium and phosphate. It's a very surprising statement which is given in Harrison, which I'm quoting here. He says, in respiratory alkalosis, when carbon dioxide in the blood is lesser and the pH of the blood is going towards alkalosis, then it can contribute to intracellular shift of sodium, potassium and phosphate. and due to intracellular shift of these electrolytes in a patient, there could be a possibility that the patient might end up with arrhythmias. So arrhythmias are written in respiratory alkalosis mainly with respect to the potassium values in the patient falling. For example, hypokalemia can contribute to torsades de pointes in a patient. Remember, the electrolyte imbalance contributing to torsades de pointes is hypokalemia. So intracellular shift of these electrolytes can contribute to arrhythmia presentation. This condition of respiratory alkalosis also contributes to increased protein binding of calcium. Mark my words there. Calcium is available in our body in two forms. One, it is available in bound form, and second, it is available in free form. What respiratory alkalosis does is it increases the protein binding of calcium, due to which the availability of ionized calcium in the blood is lesser. Due to ionized calcium being lesser, symptoms of tetany in the form of perioral paresthesias, periungual paresthesias, Chavostock sign could be given in a MCQ respiratory alkalosis. Do remember, what I am teaching you at the moment is the most common ABG disorder in chronically ill patients in the ICU. This patient has been admitted to your intensive care unit. The commonest derangement that you see is not metabolic acidosis, it is respiratory alkalosis that is seen, and the symptoms are very surprising: underperfusion of the brain, development of electrolyte imbalances, especially hypokalemia triggering arrhythmias, and then ionized calcium becoming lesser, contributing to tetany. For management of this particular condition, you obviously need to treat the cause. Treat fever, for example. Treat if there's a stroke presentation. Treat if the patient is having pulmonary edema, is having a pneumonia. For the treatment of these fellows, one of the methods to raise carbon dioxide in the body, especially if patient is cooperative, is paper bag breathing. You will give the patient a paper bag. You will ask him to form a seal around the paper bag and then inhale the exhaled air, because exhaled air contains sufficient carbon dioxide that will raise the CO2 values in the body of this patient, and therefore the cerebral perfusion effect will gradually get resolved. So I have first highlighted before you causes for these, because if in a question he gives you these scenarios, you should be able to identify, and then these rules should be remembered, that is 14 and 24, as I've highlighted 2 times. So I've just brought the slide once again to your focus, and now I think we'll be in a better position to talk about what actually would be done for ABG. So let us now study the procedural aspects which are related to performing a ABG in a patient. As you can see in the figure, we are performing what is called as a modified Allen's test, in which you are going to be testing the integrity of the palmar arch. If he says in a question, what is the reason behind performance of a modified Allen's test? It is integrity of the palmar arch. You will be serially releasing the radial artery and the ulnar artery, and you will notice the fact that in a normal individual, the entire hand will become flush and red, but if there's a insufficiency in the palmar arch, then the entire palm will definitely not become red, and therefore you can see the fact that in the patient, though you have released the ulnar artery, the entire palm is not flushed in the image on the right, and on the left hand side vice versa, it is rather that the entire palm is not red, though you have released the radial artery of the patient. For performance of the modified Allen's test, what you will do is that first you will simultaneously obliterate the radial and the ulnar artery of the patient. This is the radial, this is the ulnar artery. You'll simultaneously obliterate them. Then you will ask the patient to make a fist. So step 1 is obliterate both the arteries. Step 2 is obviously make the patient form a fist. And when he will form a fist and you've obliterated both the arteries, the entire palm of the patient will become pale. Now you will serially be releasing the radial artery and the palmar artery, and you can notice the fact that if you release the radial artery, you can have an immediate flush of the hand within a few seconds, because there is the integrity of the palmar arch in the patient. And if you release the ulnar artery, again you can demonstrate the integrity of the palmar arch. And if this test is obviously not showing an integrity, in a sense that radial artery and ulnar artery are not having a good collateral circulation, tomorrow if you do a ABG in a chap, you putting a needle in an artery, right? You putting a needle in an artery, so putting a needle in the artery will cause spasm of the artery, and spasm can contribute to development of gangrene in the long run. So always one, try to take a ABG where there's a collateral circulation. Don't take it from femoral artery as a lot of we do, and don't take it from dorsalis pedis artery. It's the radial artery which is to be used in the patient for performing the ABG. And ideally they say Allen's test has not been documented to be 100% accurate to demonstrate the integrity of the palmar arch. So the textbook mentions the fact that the use of it can neither be promoted, neither can be disputed. I mean, he says that okay, do it, but it's not a guarantee that the palmar arch integrity can be ensured. So alternative studies that should be done, a color Doppler, we can do a plethysmography, we can do a MRI, and most of the time we have a portable color Doppler available, so we can definitely use a portable color Doppler to test the radial artery circulation, and then we can go ahead with the procedure. From the procedural perspective, you obviously have to ensure that you palpate the artery between the tendon of, this is the tendon of flexor carpi radialis and the styloid process. So first feel the artery between the styloid process and flexor carpi radialis. Between the two is obviously the artery present here. You can feel the pulsations of the artery, and then you will get the kit ready for this patient after you've done the Allen's test already. You have felt the location of the radial artery which is between the styloid process and flexor carpi radialis, and now you obviously get the instrument tray ready. In the instrument tray, you obviously need a syringe that should be at least 3 ml. Usually we take about a 2 ml sample, which is sufficient. This is a rubber stopper. If you have to, after expelling the air bubbles, it is good idea to lock the tip of the needle into a rubber stopper so that any external layer may not cause contamination of the sample. And nowadays we are obviously, we are having this small portable connection which you can attach to the syringe so that you can heparinize the syringe. And in government hospitals, because this is not available, we use a standard heparin vial to heparinize the syringe and then perform the procedure in the patient. I have also shown in this diagram a roll towel which should obviously be kept below the wrist, because the wrist has to be slightly extended to stabilize the radial artery so that it can be punctured properly. And then from PSM perspective, they can ask you where would you discard the used syringe and the wrappers, etc. So obviously plastics are in the yellow bag, so yellow bag would be used for disposal. Bag of ice, why? Because if there's a delay in transporting the sample to the laboratory, a bag of ice would be handy. Once you do the procedure, you don't need to aspirate, the blood starts coming by itself. Just poke the artery gently at 45 degrees. You have palpated the artery, in this particular case between the flexor carpi radialis and the styloid process, and once you puncture the artery gently, you just need to ensure the fact that the bright red blood fills up in the syringe, and then after you have withdrawn the needle, heparinized needle, you have to press on this area for minimum 5 minutes using your thumb or index finger, or your assistant can do, and this will obviously prevent development of any kind of a hematoma. And then subsequently you can obviously see the printout and you can analyze the report. So let us now focus on some of the numerical based questions that have been asked on this topic of respiratory acidosis, starting with the first question. He says a 24-year-old beggar is found unconscious at the gate of a metro station. In the ER, the room air blood gas was performed and reveals a pH of 7.25. Now when you read this value 7.25, you immediately know that this is an acidotic pH. The PCO2 of the patient is given to be 60. So there is a elevated CO2 in the patient, and the moment you read the word elevated CO2, as I've explained to you, it should tell you that there is more protons being generated in the patient, so it obviously indicates a respiratory etiology. Now you look at the value of the bicarbonate in the patient, and the bicarbonate of the patient is 26. Normal bicarbonate is 22 to 26, so bicarbonate is normal. I have explained to you the fact that in any respiratory pathology where carbon dioxide gets elevated in a patient, there is more generation of hydrogen, so there is a production of respiratory acidosis in the patient. The bicarbonate value should increase at a rule of 10:1, that for every 10-point increase in the value of carbon dioxide, bicarbonate should increase by at least 1 milliequivalent. Let us take an average value of 40 and this guy's PCO2 60, so carbon dioxide is increased by 20 points, that is from 40 to 60. So mathematically speaking, bicarbonate should increase by at least 2 points in this guy. Since in this person bicarbonate values are normal, Therefore, this patient is having uncompensated respiratory acidosis. The answer in your question would be given as uncompensated respiratory acidosis. Why? Because the bicarbonate values have not increased in the mathematical equation that it ideally should. You can also calculate the anion gap. Make it a habit for you to calculate the anion gap, that is sodium minus the value of chloride and bicarbonate. The chloride is 100, bicarbonate is 27, so this will work out to a mathematical value of 10 milliequivalents, which means that the anion gap in this patient is definitely normal. It's a good idea to calculate anion gap because it can tell you about presence of a metabolic acidosis which could be coexistent in the patient. This question is definitely not of a mixed disorder, so you don't need to worry. The main emphasis in this question is that in respiratory acidosis, bicarb value should increase by a rule of 10:1. For every 10 millimeter rise of carbon dioxide, bicarb should increase by 1. That has not happened here, so the answer is uncompensated. Now let us compare this with the next question. A 60-year-old man with amyotrophic lateral sclerosis. You can understand ALS is a condition that will be affecting the muscles of the chest. The family members are worried that he is more somnolent than normal. He tends to sleep more than normal and he has been having morning headaches and does not feel refreshed. So probably carbon dioxide buildup in the body, and that is what is actually present here. The pH of this particular person is normal. The PCO2 of the patient is elevated. When you read elevated carbon dioxide, you know the fact that there is a respiratory component present in the patient. This patient is definitely having more carbon dioxide producing protons. So I'm writing the word respiratory acidosis as a interpretation of elevated CO2 of this particular person. In this particular person, you will notice the fact that there is a elevated bicarbonate. This elevated bicarbonate is explained by the fact that the kidney has tried to compensate for the increase of the hydrogen ions in the body of this patient. Let me apply the rule. Let us take an average value of carbon dioxide. The value in this particular question is given to be 57. Let me say average, if I just round off mathematically, it is a 20, approximately I'm saying it's a 20 millimeter rise in the value of carbon dioxide. In acute compensation, I had said it is 10:1 rule. For chronic, it is 10:4 rule. So for a 20 millimeter increase in the patient, I will say mathematically the bicarb of the patient should get elevated by approximately 8 milliequivalents. That is what has happened in this particular case. If you take an average value bicarbonate 20 to 26, I say, let me say 26 upper limit. If I add to that, this will become something like 34, and in this guy the value of bicarbonate is 34. That means the compensation process is working. First and foremost, you have to realize in this question that this is respiratory acidosis. In this particular patient of respiratory acidosis, bicarbonate value is definitely more than normal. You see, normal is 20 to 26, this is 34, so it is elevated. This bicarbonate is increased courtesy the kidney. And look at the good thing it has done. It has ensured the fact that the patient's pH has become normal. So the answer to this question will be given as fully compensated respiratory acidosis. Why I'm saying fully? Because pH is stabilized in the patient courtesy the help of the bicarbonate. The compensatory process is no big deal, right guys? Compensatory process is opposite of the primary change. Like if I ask you, what is the compensatory change of respiratory acidosis? Metabolic alkalosis. What is the compensatory change of metabolic acidosis? Invert the English words, it is respiratory alkalosis. In the exam, he will not ask you what is the compensatory phenomenon that is occurring. That is just inversion of the English words. He wants to see whether you know the fact that whether it is a partially compensated format or a fully compensated format. And if pH is normal, it is obviously fully compensated format. So the answer to this question is fully compensated respiratory acidosis. In case you missed out something, I'll quickly highlight 1 and 2 once again. If you look at question number 1 and question number 2, the difference between the two is that pH is less in this case and was normal in the second one. But in both of them, the common thing I hope you are realizing is carbon dioxide is more. And carbon dioxide more means respiratory acidosis in a patient. Whenever you see a question of respiratory acidosis based on clinicals or on value or just the value of CO2, all you need to do is look at the bicarb value in the question. If it is normal, No compensation, uncompensated. If it is elevated, it is obviously a compensation that is occurring in the patient. Now, if compensation is occurring, there are two possibilities. Either it will be fully compensated or partially compensated. If pH is normal, it is fully compensated. So this question, the second one, is a piece of cake for you because he has literally given you a normal pH. So you know that this is a fully compensated respiratory acidosis in the patient, courtesy the help of the kidney. The kidney has upgraded the value bicarbonate to 34. That is almost like, I would say, mathematically speaking, about 8 to 10 points higher. So that increase of bicarbonate has resulted in development of normalization of the pH of the patient. So for the answer is fully compensated respiratory acidosis. And this is a chronic compensation occurring. We look at the next question. You can see the fact that whenever you read the question, you should immediately think pH is 7.3, acidotic pH. PCO2 is 68, so it is an elevated carbon dioxide, which immediately tells you there is a respiratory etiology behind the problem in the patient. Then look at the value of bicarbonate. It is elevated bicarbonate. Normal is 22 to 26, and in this case, the bicarbonate is elevated, so that is helping to neutralize the respiratory acidosis in the patient. The pH has not become normal in this guy, so I will say that this patient is of partially compensated respiratory acidosis. The word partially compensated is mainly to highlight the fact that pH is still 7.3 and elevated bicarbonate is with help of the proximal tubule of the kidney, which has upgraded this bicarbonate, and therefore the bicarbonate has neutralized some of the protons, which is why this guy is still living. I've given you three situations. Question number 1 was uncompensated. Question number 2 was fully compensated. The third one is partially compensated respiratory acidosis in a patient. I'll write the data once again. In any question, if carbon dioxide is elevated, what are you supposed to do? You are supposed to look at the value of bicarbonate. Bicarbonate value is normal. Bicarbonate value is elevated. If bicarbonate value is normal in the patient, you will say this is uncompensated and carbon dioxide is elevated, so respiratory acidosis. If bicarbonate is elevated, then check out the pH. Has the pH normalized or is it still low? If the pH is normalized in the patient, you will say patient is having fully compensated respiratory acidosis. On the other hand, if you find that the pH of the patient has not stabilized, it is still lesser. The kidney is trying to do its job, but it's been not, I would say, completely successful. So this, where the developmental work is still on, is called as partially compensated respiratory acidosis. If you get this data right, you would be able to do any question based on the topic of respiratory acidosis. Let's try one more. A 65-year-old chap with a history of very severe COPD presents to the ER with worsening dyspnea and increase in the frequency and purulence of the sputum. So you are dealing with a chap with chronic bronchitis and the purulent sputum is obviously causing plugging of the airways, so he is deteriorated. His oxygen sats are 78% room air, so you can understand the discomfort and the anxious look at the face of the patient, the way his eyes would be popping out in front of you. When you have done a ABG of the patient, the pH is showing an acidotic pH. In this acidotic pH, there is an elevated carbon dioxide present in the body of the patient, which tells me that this is a respiratory etiology behind the problem of this guy. And in this guy, the bicarbonate values are elevated. Since it is elevated carbon dioxide in the patient, this means the fact that the kidney has done its job with the help of the proximal tubule of the kidney. It has not been successful in normalizing the pH of this guy. The pH is still not normal, so we will call it partially compensated respiratory acidosis present in a patient. These questions are very simple and straightforward. It is just that the mental orientation should be clear, and when you start reading about COPD anyway, you know it is respiratory acidosis, na? So all you had to do in the question was to work out the fact that whether it is a partially one or uncompensated one, pH is less than normal, so it is partially compensated. How do you know it is compensation? By carb values. Let's practice now with an open mind, and let's not think that we're dealing only with respiratory acidosis. A 15-year-old juvenile with history of inhalant abuse presents to the ER with dyspnea. His SpO2 is 99%, but he is tachypneic. Look at the pH. It is acidotic. In an acidotic pH in a patient, the carbon dioxide values of this guy is not elevated. It is low carbon dioxide in the question. So in all the previous questions, carbon dioxide was elevated. This time it is low carbon dioxide. So definitely not a respiratory etiology from the perspective of acidosis. This acidosis is not explained by low CO2. Respiratory acidosis has a high CO2. Now I will focus on the bicarb of this guy. This guy has a very low bicarbonate. So the diagnosis of this guy is metabolic acidosis, especially in a setting of inhalant abuse. Metabolic acidosis, even if inhalant abuse was not given, still metabolic acidosis in a patient. In this chap with metabolic acidosis, there has to be development of hyperventilation. You see, metabolic acidosis contributes to compensation as respiratory alkalosis, so there has to be a compensation. In metabolic acidosis, you will always notice the fact that the carbon dioxide values will become lesser. There will always be a carbon dioxide washout. Remember, small breathing is a method of compensation. In all questions of respiratory acidosis, bicarbonate elevation should occur. In all questions of metabolic acidosis, carbon dioxide washout should occur. If carbon dioxide washout is present, it means the fact that the compensatory process is successful. Otherwise, it is uncompensated, because if compensation is not occurring, CO2 values will be normal in the patient. The diagnosis of this patient will be given as partially compensated metabolic acidosis, since the CO2 value of this patient is significantly reduced. Let us now calculate the anion gap of this guy. The mathematical anion gap would be 130 minus the value of chloride and bicarbonate. You can see that the anion gap of this patient is very high. Normal anion gap should be taken as about 10 milliequivalents. This is about 30 milliequivalents. So my diagnosis for this guy is HAGMA, that is partially compensated high anion gap metabolic acidosis. You will notice in the case file we write the word HAGMA, that is high anion gap metabolic acidosis, and this is partially compensated in this patient in a sense that the carbon dioxide values are less than normal in this patient. Let us now understand a rule, whether the compensation is occurring or not. There is a mathematical rule that lot of guys are interested in. The predicted PCO2 of the patient has to be compared with the actual CO2. Predicted PCO2 value should be bicarbonate plus 15. The bicarbonate value of this guy is 2. If you add 15 to this will work out to be 17 milliequivalents. You can notice the fact that the actual value of this particular patient, the actual value of the PCO2 of the patient is also 17, and the predicted value is also 17. That means that there is a compensation definitely occurring in this patient. If this mathematical equation was not working, then it would have been a mixed disorder, which is given in the end of this particular lecture. I want you to pay attention to the fact that in all questions of metabolic acidosis, carbon dioxide should be less. Point is whether the mathematical rule is being satisfied or not, and the mathematical rule in metabolic acidosis is this formula. This rule is valid for both metabolic acidosis and alkalosis. So I'll just summarize the compensation rules which you are so worried about and have been sending me queries about. Compensation rules for respiratory acidosis are 1-4-14. What I mean by 1-4-14 is for 10 millimeter carbon dioxide rise, bicarb should rise by 1. For 10 millimeter rise of carbon dioxide, bicarb should rise by 4. 1-14, 1 is for acute and 4 is for chronic. For respiratory alkalosis, the rule is 2-4, 24. For 10 millimeter rise, 10 millimeter fall in the value of carbon dioxide, bicarb should fall by 2 milliequivalents. Acute compensation respiratory alkalosis. For 10 millimeter fall in carbon dioxide, bicarb should fall by 4, 24, right? Then it is chronic compensation of respiratory alkalosis. So 1-4-2-4. And for metabolic acidosis and alkalosis, the mathematical rule is what is highlighted in the green box, bicarb plus 15. If that mathematical value is obtained in the question, it means compensation is working. If that value is not obtained, it means it is mixed disorder. The answer to this question is partially compensated. Why? Because pH was not stabilized in this chap. High in N-gap, mathematically explained to you. The basic rule to be understood is whenever you see a question with low pH, there can be two possibilities. Either carbon dioxide will be higher or bicarb will be low. In this question, the carbon dioxide values were not elevated. It is bicarbonate lower, so that is why the answer was metabolic acidosis. Let us now do another question so that we can have a better insight into it. A 3-year-old child is admitted to the hospital with a diagnosis of severe asthma exacerbation, and the mother reports that she has noticed the child having tremors and behavioral changes. The doctor has done a ABG. The report is showing pH of 7.35. So this is a normal pH in a patient, though it is on the lower side. So it is on the acidotic side. I mean, if the question said 7.34, it would have been easier for me. The question gave 7.35. Okay, normal, but it is on the acidotic side. The carbon dioxide in the body of the patient is elevated. So one of the possibilities is that this person is having respiratory acidosis. Second possibility is person could be having metabolic acidosis. It is not a metabolic acidosis because bicarbonate is elevated. No, in acidosis, metabolic acidosis, bicarbonate should be less. So the primary change in this particular question is that patient is having a respiratory acidosis. This respiratory acidosis has resulted in development of elevated bicarbonate with help of the proximal converter tubule of the kidney. So compensation process is working. In this particular case, because the pH is given to be normal, the answer to this question will be given as fully compensated respiratory acidosis. I'm saying fully compensated because pH is normal in the patient. Had this question mentioned pH of 7.34, I would have said it is partially compensated respiratory acidosis developing in a patient. The bicarbonate values are definitely increased significantly. That is why the rule is being satisfied in this fellow. Anytime carbon dioxide is more, bicarb should rise. So this is a chronic case of a patient since he has been sick for few days. No, that's why he is currently having severe asthma exacerbation. So it could be acute and chronic respiratory acidosis also, in a sense that he was having asthma, then he was having this worsening in carbon dioxide accumulating over a couple of days. That is why the PCO2 values are so high. In fact, this guy, he might require intubation also, considering the high values of PCO2. Coming to the next question, the seventh one, you have decided to take a ABG sample from a sick patient. The pH of the patient is 7.46. So this time it is a alkalotic pH. In this guy with alkalotic pH, when I look at the value of CO2, it is a elevated PCO2. Elevated PCO2 does not explain the alkalotic pH of the patient, because elevated PCO2 should cause a respiratory acidosis, and this guy is rather having alkalotic pH, so carbon dioxide is not the cause. This guy is having a elevated bicarbonate 34, because the bicarbonate of this particular person is elevated. That means the main reason why he is alkalotic is because of the metabolic alkalosis component. The diagnosis of this particular patient first is that this chap is having metabolic alkalosis, and the compensatory change of metabolic alkalosis is respiratory acidosis. You just need to invert the English words for this. Coming to the next part, we will next talk about respiratory alkalosis in a patient, where a patient will be breathing faster and carbon dioxide values will be lesser. In the first one, a climber is coming down from the summit of Mount Everest at a height of 18,400 meters. He is having a blood gas drawn as a part of research project. Let's look at the ABG report. This guy is having a alkalotic pH. The pH is 7.35, so 7.55, so it's obviously more than normal. This guy is having a low carbon dioxide. That tells me that it could be a respiratory etiology. The bicarbonate of this patient is low. Low bicarbonate means there is a metabolic acidosis occurring in the patient. The primary change of this guy is that the alkalotic pH is due to respiratory etiology, because he is a mountaineer, he is breathing faster. So there is a carbon dioxide washout from the body, that is respiratory alkalosis is occurring in the patient. The compensatory change in the patient of respiratory alkalosis is metabolic acidosis. That is what is happening, that the kidneys have basically ensured the fact that the bicarbonate values in this particular patient remain on the lower side. The kidneys are shedding out the bicarbonate this time. In patients of respiratory alkalosis, for every 10 millimeter fall in the value of carbon dioxide, the bicarbonate value should also be reducing simultaneously. I'll just show you the equation once again if you're forgetting. This is what I had said. This was the chemistry equation that I wrote before you. Carbon dioxide is lesser, bicarb is lesser, protons are lesser. So if protons are lesser, then for compensatory changes to neutralize the low protons, bicarbonate should also be lesser, and that is what has happened in this question. In this particular case, since the patient is having a development of pH which is 7.35, 7.55, though the bicarbonate of the patient is low, it has not been able to stabilize the value of pH in the patient. The pH is still elevated, so it is partially compensated. The good news is that in this guy, the value of bicarbonate is 20. So that means the bicarbonate value has been reduced by help of the kidney. Suppose in this question, I'll just change the ink and say that suppose in this question, the value of bicarbonate was given to be 26. Same MCQ, everything same. And in the question, the bicarbonate value of this guy would be normal. That means that the kidneys have not been able to remove the bicarbonate from the system. Then the answer would have been given as uncompensated respiratory alkalosis. The learning is that in all questions of respiratory acidosis and alkalosis, just look at the value of bicarbonate, whether it is changing or not. I'm not saying going into more or less, I'm just saying see it is changing or not. In respiratory acidosis, bicarb should rise and here it should fall, and if that is happening, that means compensation is working in the patient. Because pH has not been stabilized, so it is partially compensated. Respiratory alkalosis is the answer to a question. If I change the value of bicarb to 26, then it is uncompensated value. Let's try another one. A 57-year-old woman presents with 2 days of fever, dyspnea, cough, which is productive, rust-colored sputum. So we are talking about probably a pneumococcal pneumonia. And the intern decides to do a ABG of the patient. You are having a alkalotic pH. With alkalotic pH, you are also noticing a low CO2 in the patient. That immediately tells you that the patient could be having hyperventilation as a cause, contributing to carbon dioxide loss, and therefore the patient is having respiratory alkalosis. You will now look at the value of bicarbonate, and bicarbonate value is on the lower side of normal, but it is at least normal mathematically, because the bicarbonate in this value is in this question is normal. That means the fact that in this patient the compensation process has not started, so the diagnosis of this patient will be given as uncompensated respiratory alkalosis. Suppose in this question, I'll change the ink and say, suppose in this question the value of bicarbonate is given as 20. Same question and the value of bicarbonate was given as 20. That means the fact that the bicarbonate has been lost with help of the kidney, and then I will say patient is having partially compensated respiratory alkalosis. If the pH will normalize, then it will become fully compensated. Usually they don't give you questions on fully compensated, because what will he ask? No, after all pH is normalized. So either he will give you uncompensated or partially compensated. And how to work it out? Look at the value of bicarbonate. If it is normal, uncompensated. If it is elevated in respiratory acidosis or decreased in respiratory alkalosis, it is partially compensated. So he is himself telling you the answer in the first go. You see, most of you are hell-bent on doing mathematics in this question. I'm saying if you just use common sense, half the job will anyway be done in the questions. This is partially compensated respiratory acidosis if the value of bicarb is low. Otherwise, the standard way the question is given, it is uncompensated variety. Try doing all of these questions in the because they're given after this also by yourself. Try to do them faster. Try to do them with concentration, without any music on, without any internet on. And when you try to do them faster, this will become a reflex for you. This will become a second nature for you. You won't have to, struggle in wondering what these mathematical parameters are saying. And as I've said so many times, we doctors are bad at mathematics. That's why we took up biology as our career. And little did we know that one day we will be solving questions of the ABG analysis. So, well, mathematics is something which is a sore point for doctors. That is why I get messages from most doctors saying that we are having trouble with ABG. So I thought let me just come out with this. The pH of the patient is alkalotic. For alkalotic pH, there are two possibilities. Either it could be respiratory or it could be a metabolic problem. Let us see what is the problem of this guy. In this guy, you can see PCO2 is less. So immediately tells me it is a respiratory alkalosis in a patient. Why? Because the bicarbonate value of this particular value is 25. This guy is having a bicarbonate value of 25. So that means that if bicarbonate was, you see, elevated, I could have thought of metabolic alkalosis. But bicarbonate, this guy is normal. So that means the fact that in this particular chap, there is a presence of a uncompensated respiratory alkalosis. The bicarbonate values have not reduced, they should have reduced. If in this question bicarbonate values were lesser, I would have answered it as partially compensated. And if bicarbonate values are elevated, that means patient could be having two simultaneous mixed disorders, which will be towards the end of this discussion, where patient can have both respiratory alkalosis and metabolic alkalosis. So we will come to those questions where you get mixed disorders, but at the moment just focus on the reflex of working on the questions of respiratory alkalosis. Moving to the next question. A patient is admitted to the hospital and is to undergo brain surgery. He is very anxious of the Fred surgery. He begins to hyperventilate, so half the job is done. In any guy with hyperventilation, there will be a carbon dioxide washout from the body. This guy has a alkalotic pH. There are two reasons for alkalotic pH. Either it should be low CO2 or it should be elevated bicarbonate. In this particular guy, the bicarbonate value is normal, so therefore bicarbonate is not the cause of the problems of this guy. In this particular guy, the carbon dioxide is less because of hyperventilation. This is the standard presentation of anxiety, as I was saying earlier. So this guy is having a respiratory alkalosis of the uncompensated variety. Why uncompensated? Because the bicarbonate values are normal in this patient. Had they been lesser, had they been given to be 20, 18, 15, whatever, if they were lesser, I would have said partially compensated. In the next question, you can see that pH of the patient is 7.4 through, that is normal pH. There is a low CO2 of the patient, so there is a respiratory etiology behind this. And there is also a low bicarbonate in the patient. Low bicarbonate indicates the fact that patient could be having metabolic acidosis. Low CO2 implies respiratory alkalosis in a patient. Carbon dioxide washout will decrease the protons. And the patient would also be having simultaneously metabolic acidosis. So the two processes will cause the pH to become normal. So one thing is very clear. This question is of fully compensated variety. Now it is my job to find out that is it a respiratory acidosis or alkalosis. So the correct answer for this would be that this patient is fully compensated respiratory alkalosis. In the absence of clinical information provided in the question, it will not be possible at this juncture for me to know, unless I have a previous ABG report, what was the primary cause for the problem of this guy. Was he having a problem of lungs, or was he having a metabolic acidosis initially? So it is not possible with a single value at this juncture to work out the primary change. And anyway, if the pH is normal, there is absolutely no reason to work out the primary change. Primary change is always to be worked out in the uncompensated varieties. Remember that words there, right? You work out the primary change in the uncompensated varieties. If it is fully compensated, well, why do you want to interfere? The basic point is patient is having two processes simultaneously working out, which is causing a normal pH of the patient. So the answer to this question would be given as C. This is a chronic respiratory alkalosis in a patient. Let's do some mathematics. Carbon dioxide in the body can be taken as an average of 40. In this guy, the value of carbon dioxide is 25. So the change of carbon dioxide in the body of this patient, if I take mathematically, is about 15 millimeters of mercury. Since this guy is having respiratory alkalosis, in respiratory alkalosis, I spoke about the rule of 24, that is for every 10 points decrease, there should be a decrease by 2, and for chronic it should be 4. So if this is 15, mathematically speaking, the rule is like this: 10 millimeter fall in the value of carbon dioxide should cause 4 milliequivalent fall in the value of bicarbonate. This is the rule. If it is 15 instead of 10, so that will make it like maybe 1.5 times higher. So if I multiply 4 into 1.5, this will become 6 milliequivalents. Mathematics coming up here, sore point for most doctors. 15 millimeter fall in carbon dioxide should cause this to fall by something like 6 milliequivalents. If you take the bicarbonate lower value to be 22, in this guy the value is 18 plus 6, or let me say if you take average value bicarbonate as 24, 22 to 26 is the range. 24 minus 6 would be 18, and that is the value of this question. That means compensation is occurring adequately in this particular case. There is an adequate compensation occurring in this case. That is why the pH of this particular patient is normal. Even if you don't go into the mathematics that I said here, it doesn't matter in the exam because you don't have time to do all this. So there is no need to go into the mathematical skills. Most of the questions in the exam are one step logical process. One step logical. If you're thinking too many steps, your thought process is wrong. Let me put it this way. So if you get this information right, the initial upper part more than sufficient. Do try the mathematics by yourself, and I think I made myself clear. Average bicarbonate is 24, range is 20 to 26. This is downgraded by 6, that is the value of 18 which is present in the case. So this is adequate compensation occurring. Coming to the next question. pH of 7.56, what is the alkalotic pH? In this patient, the PCO2 of the patient is low, so probably a respiratory etiology, and the bicarbonate of the patient is also low. Low bicarbonate tells me the fact that in this patient there is a concomitant metabolic acidosis. So the logic is this guy is having respiratory alkalosis. In the compensatory process, the kidney is trying to kick out the bicarbonate, so metabolic acidosis also. Since the pH of this particular patient is not normal, it is obviously partially compensated. I am ruling out uncompensated in the question. Why? Because if bicarbonate value was normal, I would have said uncompensated. Now here the bicarbonate values are lesser than normal, so it is partially compensated. The diagnosis of this guy would be given as partially compensated respiratory acidosis. Why it is not D? Because metabolic alkalosis should have a elevated bicarbonate, and in this guy the bicarbonate is less. So two choices can be easily ruled out because bicarbonate has been lost with the help of the kidney in a patient of respiratory alkalosis. This guy is having a partially compensated respiratory alkalosis.